Rise time is in seconds, and then it's about, and what rise time does is that, what is the percentage of the breath time? What is the time that it takes to deliver the breath? Are you going to deliver a breath in a very short period or at a very long period? If you deliver it at a very short period, one is you cause the patient to now begin to breathe against the next initiation of breath, which can cause turbulence and then increase the work of breathing. Another thing is cycling. Another thing you hear about mechanical ventilation is cycling. Cycling means that it's like you're changing over from NEPA to your generator. You're changing over from inspiration to exhalation. That changeover is what they call cycling. So it could be pressure cycling, it could be volume cycling, all this we'll discuss later. Another key thing that is important is what they call the expiratory trigger sensitivity. You can see the ETS basically on most ventilators. ETS means that what is the percentage of the, the peak inspiratory flow, the maximum flow of gas that you're delivering to a patient in the phase of inspiration. What percent of each do you want it to flow to the patient before the machine or the patient now stops inspiring and now begin to exhale? That is what you have to call the expiratory trigger sensitivity. Most machines will actually place this at 25%. Both of the new machines will place this at 25%. We're done with some definitions. As we read more about mechanical ventilation, more definitions are coming in as products actually increase in number. But look at what are the types of ventilators. One, we have the negative pressure ventilation and then the positive pressure ventilation. We're all aware about the iron lungs at the period during the period of the poliomyelitis epidemics in the 50s. But it was found out by some studies that they actually use iron lungs in Boston Children's Hospital as far back as 1928. So everything is all starting like anesthesia in Boston. So Boston actually, it could claim credit even though during the poliomyelitis era was when, by the iron lung, what it means that they're trying to mimic the natural process of ventilation, in which you have some stimulus from the brain and then your diaphragm, contracts, increases, expands the intrathoracic space and then creating negative pressure, allow the egress of air. That's what they're trying to do by the negative pressure ventilations. I heard some places they are trying to reintroduce it to clinical practice, but it is not very commonly used. What is commonly used now is the positive pressure ventilation, which from reports also found out it was used first in 1955 in Massachusetts General Hospital. So another type of mechanical ventilation is invasive, non-invasive. If you use either a tracheostomy or you use tracheal intubation, this, as far as you breach a body cavity, before you breach a body cavity, that defines what invasive ventilation is. The non-invasive means you're using lots and lots of interfaces. Interface will be your face mask, it will be your nasal mask, it could be your hood or whatever it is. If you use any of these interfaces, without breaching the body cavity by, like I mentioned before, tracheal intubation or tracheostomy, this what defines the non-invasive. So you can be doing mechanical ventilation and you're not intubating the patient, but you're using the non-invasive ventilation. Another type is the pressure cycled ventilation and then the volume cycled. We're all aware about these terms. Pressure, you said the pressure. What varies is now the volume. Volume cycle means you said the volume, you preset the volume. My ventilator deliver 200 mils to this patient. Ventilator will just do exactly that. Ventilator, I said the pressure.
Pressure cycle deliver a fixed pressure at variable volume.
Should I stop? But I think you can actually mute anyone who is disrupting this process. You can mute the person I mean,
Yeah, that is what we are doing, Dr. Job. Go ahead. So we are muting them. Just go ahead. Thank you.
We are looking at types of mechanical or types of mechanical ventilation.
Yeah.
And we said one, we have invasive, non-invasive. We have pressure cycles. We have volume cycles. Then these are the types, and then negative pressure and positive pressure ventilation. So that. So examples of pressure cycle ventilation. What I mean by pressure cycle ventilation is you are setting the pressure. This is the maximum pressure I want machine to deliver to this patient. Machine delivers just that and does not exceed that. Example is the pressure support ventilation, the pressure control ventilation, our Cpap, our bi-level positive airway pressures, they're all forms of pressure cycle. What you set is just the pressure, and the machine delivers a volume. The volume is basically dependent on the pressure you preset. So what is variable is the volume, but what you set is just the pressure. And these are examples of the pressure cycle ventilation. And then we're looking at the volume cycle ventilation. The volume cycle ventilation delivers a fixed volume at a variable pressure. And these are what we call the control, assist control, and then intermittent mandatory ventilation, and then our popular SIMV. Let's quickly run through the modes. Modes basically defines the interaction between the spontaneous breaths. Spontaneous breath is just every effort the patient makes on its own. That is spontaneous breath. And then what is delivered by the machine. That's what defines a ventilator mode. All the modes we're talking about is that interaction, between what the patient is making, the effort the patient makes, and what the ventilator defines, and then what the ventilator provides. So that's what it means by the modes. And don't forget the fact that in defining the modes, whatever mode you're using, there are two things involved in it. Are you presetting pressure or are you presetting volume? There are three terms that could be confusing if using newer concept of mechanical ventilation. One is we're used to the mandatory breaths, the mandatory modes, and then the assist, and then the spontaneous modes. The newer ventilators now, the newer concept is they don't use mandatory, they don't use spontaneous. They use control and assist control and assist. Let me not confuse anyone. Control mode means that the ventilator is taking full control of everything. It initiates the breaths, it terminates the breaths. The patient has no role to play in a control mode. So you can see some control mode like the continuous mandatory ventilation or our popular IPPIV, in which you set the patient on the ventilator and the machine just delivers it. The assist control means patient makes an effort. The machine senses that effort based on the sensitivity parameters we've preset on the machine, and then supports that effort that is made by the patient. This is what assist control refers to. They don't mix it up. Control mode, machine is doing everything. Assist control, the two are sharing. Machine will deliver some mandatory breaths, but sensing what the patient does and then delivers some form of it and supports what the patient efforts the patient makes. Then the assist means the spontaneous breath. The patient is not making effort breathing on his own, and then initiates and terminates it. And then we have these other forms like the SIMV, which is basically a spontaneous mode. But in the spontaneous modes, the machine senses SIMV basically an assist control because the patient makes efforts. The machine recognizes that effort made by the patient and then synchronizes those mandatory breaths with what the efforts the patient makes. In between, the patient is breathing on his own, but machine still synchronizes breath stacking and then the synchrony. Then we have the piece, I've talked about some of this before. So in a nutshell, let's look at the mode again. The pressure control ventilation. We have pressure control means is a pressure regulated. Is pressure cycled. It's not volume cycled. And because it's a pressure control ventilation, no patient participation, everything is done by the machine. When you use this mode, patient is not participating, and then you deliver this only, you know. And then the PSV, which is a very common one, determines the patient is determining the rates. In the PSV, basically used for, like, we use it most times when you want to wean off the patient, or you want to assess the patient's recovery from paralysis. In a PSV means that you add some pressure supports, and then it could be, you can have a patient who is spontaneously breathing, has a volume cycles ventilation, and then you want to just support every effort the patient makes and see if you can use it to assess the patient and see how much the patient is actually making. And then we have this pressure regulated, ventilation. In the pressure regulated, the PRCV, pressure release ventilation control. What it means is this: for every effort the patient makes, the machine senses the volume that the patient makes and use it to determine the pressure that it adds to the next volume. It's simple. For every effort the patient makes 100 mils. The machine now senses it, increases the pressure so that to increase the volume to 200 mils. That's what the pressure regulated volume control means. And then we learn about the Cpap and then the bi-level ventilation. So I've talked about the control. Everything about control is, I've talked about the assist control, which is very most common, that SIMV that I often use. I will say the patient makes effort, then the machine adds some mandatory breaths and also supports the efforts that is made by the patient. So how do you do all this? Assist mode means everything is initiated by the patient, and patient takes full control of the respiratory rates. We talk about the some volume control using some pressure support. The one is on SIMV, and then you put a pressure support of 10 or 5. I mean, for every effort the patient makes, the patient senses it and supports it to increase the volume. If you test it on the ventilator, you will see it. To increase the volume from what you preset is like 500 mils, and then the patient is making 200. You add pressure support. Whatever effort the patient makes, you now support it now to the next level. These are the things what about the settings, ventilation settings for volume. You preset tidal volume, there's a flow waveform, then you backup rates in case of any apnea. You set up a backup rate, and then you also preset the respiratory time, and then what triggers sensitivities. Don't forget the FiO2 and then the PEEP. For the pressure supports, they are the kind of settings you place on the ventilator. The peak pressure, respiratory time, backup rates, respiratory trigger sensitivity, and all that. Then this is a typical ventilating setting. Talk about the pressure regulated and then the volume regulated. What are things, the parameters are actually set on the ventilator. For disease-specific ones, the RDS is same thing, same ventilation settings. You look at what you preset, and then, like we said, it can cause harm, and then look at the dangers as well. Let's talk about the monitoring. What do you monitor when a patient is placed on a mechanical ventilator? Their physical presence is the key thing. Your clinical assessment of the patient. You know the disease the patient are presented with. The ventilator does not cure the disease. What the ventilator does is support in improving the clinical parameters the patient will present with. So the ventilator is not a cure for the disease. So you have to continuously physically assess the patient clinically, all the vital signs, and see how the patient is, whether the patient is improving or not. For the patient that is on a ventilator, the chest X-ray is a key thing. Once the patient is intubated and the ventilator is initiated, the first thing you do is to do a chest X-ray to see where a tube is, whether the tube is in the bronchial or your tube is in the right place, and then the risk of having a ruptured bulle or whatever it is that will cause pneumothorax. So chest X-ray is key in monitoring patients who are on a ventilator. The use of the ABG is key. We all know it very well. I use ABG to see which of the parameters and in defining the minute ventilation, which of the parameters will you want to alter? Look at the PaCO2 and then the PaO2, and then the hemodynamic monitoring. We're using positive pressure drive. So in the positive pressure drive, we're increasing the intrathoracic pressure. So it creates to create an imbalance in the vital signs. So monitoring the vital signs is quite key. And then we talk about the respiratory plateau pressure, and we must keep it below 30, and then the continuous pulse oximetry the capnography, and transcutaneous monitoring. Ventilator alarms is key, visual or the audible. These are things that must be assessed. Some ventilators actually can assess nutritional assessment, do assessment, and then it's quite important you also look at that. And then, so the likely questions that residents could be asked could be classified mechanical ventilation. We all know it very well that ventilation could be pressure, could be a negative pressure ventilation, positive pressure ventilation, invasive ventilation, non-invasive ventilation. Is it pressure cycles or is it volume cycles? So things can happen. Before they ask you, what do you advise for CMD to look out for in buying a mechanical ventilator? One, must be robust, must be easy to use, user-friendly, and then there are two types of ventilator. I look at what we call turbine and the compressor-driven ventilators. In some places where gas is a big problem, some turbine keep working even when the gas flow has stopped. So if you look at the availability of gas, that also help you define what you want. Is it a turbine or is it a compressor-driven ventilator? And then the access to biomedical assessment. So if you buy a ventilator that is very complex and you don't know how to use it, it becomes a big problem. Indications, we talk about indication, primarily 60% is repeat failure, type 1, type 2, type 3, and then the coma and the rest. And then how do you manage the patient on the ventilator? Clinical assessments, and then you begin to assess and then look at the other parameters using vital signs, clinical signs, and then ABG and all that. I've talked about this. So in summary, mechanical ventilation is a life-saving procedure. It is a device that actually has an integral part of our practice, both in anesthesia and critical care. And then the overall goal is to improve oxygenation and then ventilation. And I said ventilation has got to do with carbon dioxide exhalation. You must use any mode that is easily accessible to you. There are very complex modes that are being used by various manufacturers, but the one you're used to, use those ones. And then monitoring is very essential. Good ventilators actually will ease satisfactory practice. When questions come, we can now look at other issues. These are my references. Thank you.
Thank you, Dr. Joe, for extensive discussion on mechanical ventilation. One, I really appreciate you for the way you describe it. Thank you very much. And to our viewers and listeners, let me Dr. Joe discuss with us this evening. First and foremost, the topic is, for the sake of those that have just come in, mechanical ventilation, and he's taking the first part of the topic. He started by brief history on how mechanical ventilation started, and he made mention of the goal. Why are we trying to ventilate a patient? And he made mention of the primary aim and, of course, the secondary aims of ventilating a patient. Primary, and of course, there are other aims which are secondary aims, among which is trying to not over-labor or ventilator on the patient. Things that happen naturally with regards to inhalation and exhalation and the ratio, ratio 1 to 2. He also made mention before putting patient on mechanical ventilator, among which he mentioned the normal the airway pressure is exceeded. Also, he mentioned, or he gave us a definition of compliance, both static and dynamic. Then what is trigger? Then he made mention of cycling volume or pressure cycling. Then type of mechanical ventilation, which the current mechanical ventilator we are using now, which is a positive pressure mechanical ventilator. He also made mention of the ventilation could be invasive or non-invasive. Of course, I assume we all know what invasive ventilation is and non-invasive. The use of tracheostomy, whereas the non-invasive include maybe the. He made which could be pressure cycle and volume cycle. He also made mention of other parameters which could be on mechanical ventilation, which include the Cpap, the BiPAP, the PCV, and the PSV, which is a pressure support ventilation. Of mechanical ventilation, which is the primary thing put a patient on mechanical ventilation or assist control. Control means the patient is doing not assist control means effort, but it is complemented by the mechanical ventilator. And he also mentioned have different mode like the SIMV, the PCV, the PS. And in addition, he talked about setting of mechanical ventilation. And of course, he made mention of patients who have primary lung injury and patients that does not have primary lung injury that need a mechanical ventilator. The management, the setting is not the same, especially patients with acute lung injury and patients with ARDS. He concluded when a patient is put on mechanical ventilator. So primarily, the patient needs to be assessed, which he mentioned that the physical assessment needs to be done. He also said the endotracheal tube, which we commonly use for mechanical ventilation, you need to know the tip or the distal end of the tip. And if it is possible to have a mobile X-ray, that will do a long, it will help in knowing the distal part of the endotracheal tube so that you won't do one long ventilation. However, you can actually confirm that through other means, either through fluoroscopy or maybe clinical judgment by listening to the chest wall. Gas analysis, which is the primary thing that we need to have to know that the patient is adequately, as in adequately ventilated. Hemodynamic status of the patient needs to be assessed from time to time, and where necessary, the parameters needs to be adjusted to be sure that the hemodynamic is not further deranged, because there is tendency that there will be hemodynamic abnormalities in patient on mechanical ventilation. One of the devices that can...
Moderator, please, can you allow the presenter to address the questions? Thank you.
All right. Sorry. Thank you, Ma. Okay. I'm not having a question with me right now. I don't know if I can be forwarded.
There are questions on the chat. So please look at the chat. And if the presenter can see the chat, there are questions to be answered.
Oh, thank you, Ma. All right. Let me go straight to the questions.
No, excuse me, sir.
Sorry, Dr. Job, are you ready?
Excuse me. I thought there are two presentations today. So I'm thinking because the questions are for me, some are for
part of the presentation will be taken next week. That's to my knowledge.
Because okay, like I'm looking at that.
Is please.
I'm looking at the chat box.
ERVC.
Hello, Dr. Job. Thank you very much. Dr. Gafar, thank you for the good moderation. Please, can you hear me, Dr.
Yes,
Job?
Yes, ma'am.
Dr. Gafar, can you hear me? Okay, good afternoon, everybody, once again. Thank you so far. We have 2 sessions. The question and answer session for this part 1 of the ventilation, you will take it. So please, if you can kindly, Dr. Job, open the chat box and read out the questions that have been presented to you as they come. We have some other questions which we will take in the next 10 minutes on exams, general exam questions, which we will take up, we'll discuss as the second part of the session for today. Thank you very much. Well done.
I've tried to answer some of the questions I saw. Yes, ma'am. I have tried to answer some of the questions I saw on the chat box. And then there's the one
don't
that
answer, don't answer them on the chat box, please.
Okay.
Read out the questions and then answer it verbally, because not everybody is following the chat box. Or you want me to read it out to you, then you can answer.
Okay.
How do you want it? From the chat box, I can see the first is, thank you for the presentation. Please, can we have the slides today? Yes, generally we always provide the slides after the presentation on the YouTube channel and on the website. And we send to individuals on request, and we also paste it on the NSA WhatsApp group. So the second question is over to you from Olukayode Opadola. Says, please, can you expatiate on PRV? Can you hear me?
Yes, ma'am. Okay, for PRVC.
Yeah, okay,
the network is breaking, ma'am. Go ahead, ma'am.
Okay.
I can hear you, ma'am.
Dr. Job, okay. Well, take over the moderation and the questions, and let's be snappy about it.
Okay, ma'am. Yes, ma'am. For PRVC, a patient takes a breath. The ventilator senses the breath. And if the volume is lower than the preset volume, the ventilator increases the pressure. It's a pressure release ventilation, mode. Patient takes a breath with like 400 mils, and then the ventilator senses it and assumes that volume is lower than the preset volume. So what the ventilator does is to release more pressure to now augment the next breath to increase the volume of the next breath. Instead of you preset 400 mils, ventilator delivers 400 mils. In this case, it's one of the new modes I found its usefulness in some clinical situations where you deliver 400 mils and the ventilator senses that the patient requires much more than that. So the ventilator now increases the pressure on its own to now increase the next breath, increase the volume of the next breath. That means every breath is not static, it's not the same volume for every breath. Every breath is assessed, and then the next breath is determined by what is delivered now by the ventilator. What the ventilator does is senses it, the volume is not adequate for this patient based on the specific drive of the patient, and then the metabolic needs of the patient. The ventilator on its own now increases the pressure. Normally there is a ceiling pressure, increases the pressure, and now uses it to augment the next breath to a higher volume than what the patient has had. That's what the PRVC means. Another question they asked me, issue of weaning, I won't discuss this, but that will be, and the complications of mechanical ventilation will be discussed next week. Somebody asked about, please, can you the volume cycles ventilation. Volume cycle is simple. You preset a volume. I want the ventilator to deliver 400 mils based on the weights and then the predicted body weight of the patient. When you preset this, it means you impute this into the ventilator. The ventilator will deliver that. What changes, what varies between volume cycle and pressure cycle is simple. For volume cycle means you preset the volume. What varies is just the pressure. But what you get, the volume that you preset is what the ventilator delivers. But what will vary? There are advantages, there are disadvantages. If you have a patient probably who has maybe pulmonary edema or some influx of fluids into the chest and is increasing the pressure, it means that the preset volume that you've made will not be delivered. The ventilator will end up hypoventilating the patient because you've already fixed the volume. But for a patient like that, you need to change it from volume cycle to pressure cycles. So one that an inbuilt, pressure in the chest wall, in the lungs, the ventilator automatically delivers much lower to that we won't have any barotrauma or volume trauma. That is just that. Somebody also asked about the difference between bi-level and then Cpap. If you look at the BiPAP machine, you have EPAP and IPAP on every bi-level machine that is on normal ventilator. Either on normal ventilator or the BiPAP ventilator on its own. You have bi-level means bi-level, BiPAP bi-level. Bi-level ventilator means 2 levels of pressures, 2 levels. And the 2 levels are one, the inspiratory positive airway pressure, the IPAP, and then EPAP. The EPAP is like Cpap, but the pressure you exert at the end of expiration is Cpap. So you only adding a pressure support. So that is the difference. BiPAP and Cpap, they are just the same. The only difference is that there is Cpap in BiPAP. The EPAP, the expiratory positive airway pressure, is Cpap. But Cpap is continuous both in inspiration and expiration. So the 2 components of BiPAP are Cpap. Oh. Can we mute these guys who are disturbing us, please? So that is different between Cpap and BiPAP. They are just the same. Cpap is in BiPAP because the EPAP of BiPAP is in Cpap. What it means that BiPAP means you're just adding pressure support to Cpap and it makes it BiPAP. You're adding pressure support to Cpap. If you see if you have a ventilator and you see the Cpap mode, once you add pressure support to that mode, it becomes bi-level. It becomes BiPAP. That's another question. For ventilator associated pneumonia, and that will be discussed as part of the complications of mechanical ventilation. So I think the next sensitivity. Okay, a question on sensitivity setting. There are two cyclings. You cycle from inspiration to exhalation. If you breathe in, like our normal, what initiates our inspiration, the diaphragm contracts, increases intrathoracic space volume, pressure drops, air goes in. At the end, the expanding phase is basically a passive phase. The lungs just retracts, uses of some of the accessory muscles of respiration, and then they help to reduce the intrathoracic volume, and air naturally egresses at expiration. What happened with the ETS, the expiratory trigger sensitivities? When do you want the ventilator to change from delivering gas to the lungs to allowing gas escape from the lungs? When do you want it? Do you want it? What everything is timed. If the time cycles trigger, if you are delivering like if you preset respiratory rate for like 12 cycles per minute, you have 60 seconds in 1 minute. You have 60 seconds in 1 minute. It means that in 1 minute of 60 seconds, you're delivering every breath takes 5 seconds. It takes 5 seconds to deliver a breath. And a breath has an inspiration and exhalation. So if you set the IE ratio as, let's say, 1:1, in 5 seconds, can we move that? Okay. I'm going to discuss about sensitivity triggers. Now we have an inspirating phase and we have an expirating phase. The machine must cycle from inspiration to exhalation. Gas flows into the lungs in inspiration. The machine must open up the expiratory valve. There are 2 valves in the ventilators, in the ventilator. One valve is to allow air goes into the lungs, which is the inspiratory valve. The other valve is the expiratory valve to open. When this expiratory valve is open, air naturally now egresses from the lungs into the circuits. So you are defining by the ETS at what level of inspiration, what is the height of inspiration do you want the machine to start cycling back to exhalation? If you want, once they start delivering gas, once the peak inspirative flow is like 1%, once that delivered, everything has finished, you've already delivered the whole gas to the lungs before the process of exhalation, which is much longer than the inspirative phase, will commence. So what most machines do is to set it, they set the ETS as 25%. That means the machine has delivered 75% of gas into as inspired air, after which the machine will now start, the process of exhaling this gas away. And by doing this, you don't give room for the patient is making, assuming for somebody who's making effort now, patient is making efforts, but then the patient is making effort to breathe, machine is already delivering, or the machine has stopped delivering, and that will cause some forms of desynchrony. That's what the most manufacturers don't want.
Microphone, please.
That's what most manufacturers don't want to occur. So they set the ETS as 25%. That means the machine delivers 75%. By the time you finish delivering the 75% of the tidal volume, the ventilator will now start cycling back to exhalation. If you look at the graphics, we will discuss the graphics, maybe ventilator phase 2. We will understand it better. Look at the graphics. You finish delivering the gas, then the ventilator starts cycling back to exhalation, which is a longer period. So you don't want to finish, delivering, and then the next process now starts very late. At which time the patient will now start making effort to breathe again, and that will cause desynchrony. That's what ETS actually means. If you read more about ETS sensitivity triggers, you understand it. Sometimes it can appear very difficult to explain sometimes, but that is how it is. More questions? I don't know whether I have answered anyone that is missing. You can explain to me.
Dr. Job, I think there is a question on transcutaneous monitoring for patients on the ventilator. How do you go about transcutaneous monitoring? I think there's a question like that on the chat box. I don't know if you saw that.
There's a pulse oximeter that they use to assess cerebral oxygenation. It's a transcutaneous monitor. I don't think it's available in this country, but there's transcutaneous monitor that they use to assess cerebral oxygenation. Cerebral oxygenation, and they'll use it as a transcutaneous monitor. Normally, for patients who are, if you're ventilating a patient and you want to see the PaO2, if you're using the central venous oximetry and to assess how much of your the oxygen is you find in the brain, or that's actually gone through the carotid, you actually use the transcutaneous monitor to assess such patients.
Thank you very much, Dr. Joe. There's another question here on the chat box, and it says, is there a specified protocol on how often the ETT is to be changed for a patient on mechanical ventilation in ICU, just as we have for the central lines based on sites of insertion? Is there a specified protocol for the change of the endotracheal tubes for those patients who are mechanically ventilated?
The key issue is once you breach, if you use if you do tracheal intubation, you do invasive ventilation, you're breaching some natural defense systems in the patient. So you prone this patient to infection, which is the commonest is ventilator-associated pneumonia. So most times, unlike central lines, you can have antibiotic-coated central lines that could stay for like a month, can stay much, much longer. For tracheal tubes, there's of tube blockage, and then the risk of VAP, ventilator-associated pneumonia, they're all there. So what you allow is, you assess the patient first, as if it's a patient that will be on the ventilator for a much, much longer time more than 2 weeks. At the outset, you can actually offer the patients tracheostomy. For a patient you know that we're going to be on a ventilator for a very long time, you can offer the patient ab initio tracheostomy. Otherwise, 2 weeks, 10 days, or from 7 to 10 days are all required to actually change the tube from. You can actually re-intubate the patients. Some protocols actually kick against the use of the tube exchanger because of the risk, the trauma it causes, and then some people I've read the case report where they said use tube exchanger is probably very dangerous and risky. But 7 to 10 days, you can actually allow the tube to actually be in situ for 7 to 10 days, for the maximum of 2 weeks after we offer the patient's transfusion.
Okay. Thank you. Thank you very much. I think most of the questions on the chat box have been answered. Somebody is asking again for the slides, and I think Madam President have addressed that. The slides will be sent to you or can be on the website. Then somebody is asking about being added to the WhatsApp group. You can send your WhatsApp number and you'll be added to the NSA WhatsApp group chat. Yeah, the second group chat. Now we are having the next presentation. I think now we can go over to the next session. I don't know if the moderator is still with us to direct the affairs of this webinar. Dr. Are you still with us? Dr. Nee, are you still with us? Dr. Gafar.
Dr. Nkechi?
Yes, okay. Yes, I am. Yes.
Okay, thank you. Please continue with the moderation for the webinar. We are through with Dr. Job's presentation and questions and answer session. Yes, good afternoon, Mark.
Yes, does he know?
If you say something, Professor.
Yes, I'm saying that does Dr. Gafar know the context of the second part of the presentation. Have you shared the questions that we'll be addressing?
Yes, I sent it. We have
Does he
about
have the
two
questions?
Yes, yes. We have about 2 questions.
Okay.
The questions I sent to you, Ma, were the ones on the NSA mail.
Does Dr. Gafar have the questions?
Not with.
Yes,
Then
he has it, Ma.
share the question with everybody.
Okay.
Okay.
So,
right. Okay.
Section
Okay.
So
on exact anima.
all right, go
We
ahead, please. Go ahead.
There is a question from Dr. Elumelu regarding this same. Is Dr. Job with us about ventilation? I think he can also take this question. Dr. Job, are you with us?
Yes, yes.
Okay. Dr. Elumelu is asking about, there's a question she threw open in the NSA Yahoo Mail page. She's asking about the setting up and adjustment of clinical of our ventilators. She said that in Saudi Arabia, the respiratory therapists work with the ICU doctors to set up and adjust the ventilators. Now we don't use respiratory therapists in Nigeria, at least in most centers. We do our own setting up and adjustment based on our clinical assessment and feel in Nigeria. She said that she noticed that the therapist here uses the ABG results, particularly the PCO2, to adjust the ventilator rate. And they seem to use a formula when they do this and a calculator. So did you come across this in your presentation, when you were preparing your presentation, about the use of the formula and what does it involve? She's trying to find out. I don't know if you have an idea about this formula that the respiratory therapy used to adjust the ventilator settings.
Yes,
Thank you very much.
There are respiratory therapists who are like our anesthetic technicians. Anesthetic technicians work with the anesthesiologists in the OR, where the respiratory therapists actually work with the intensivists in the ICUs. For every patient, basically, it's like your technician will be playing with your anesthetic machine. That is the way. But the clinical assessment of the patient and the intensivist is the person in charge of the patient. So there are determinants of, I'll put it now. In my slides, I was showing something about what do you do? How do you troubleshoot a patient who has hypoxemia? What are the factors that affects oxygenation? And what are the factors that affects ventilation? For carbon dioxide, you need to tamper with the respiratory rates. The issue of using, if you have a PCAO2 of 60, if you have a PCAO2 of 60 maybe on the ABG of 60, it means that the patient is hypoventilating. You need to naturally increase the rates of ventilation so as to drop down the level of PCO2. So it's not any formula, it's a clinical assessment of the patient that determines what you do. ABG is easily available in some places. Some places they don't have, the ABG is very expensive. So you don't have ABG and then you have capnography. Yes, you can access it indirectly. Otherwise, you clinically assess the patient and know what ABG serves as a guide, because if the carbon dioxide level is increased in the arterial blood, what it means that you got to increase the respiratory rates. And in assessing the respiratory rate for a place where you have easy access to ABG, you can do it as many times to correlate with to your targets. It depends on what is the targeted values. But there must be targeted values. You can see a patient who has COPD that will have some permissive hypercapnia, and you want to go and tamper with the carbon dioxide level with the respiratory rate. So you actually have targeted values of your PaCO2, targeted values of your PaO2, depending on the clinical state of the patient. What the patient is presenting is what you are seeing. And then other parameters, you can actually use them as aids, as guides. Anyway, I don't know about the formula. they are trained as therapists who work on the ventilator, so they can have a lot of formulas they can actually use. But I think that the onus is on the intensivist. But he is the physician who is managing this patient and understands the disease state of this patient and should be at liberty to actually tinker with whatever he thinks is not a targeted value. The values he wants to assess are the values he has already created. They are the values he should actually work with. That's what I think anyway. But they are there. We can, in Nigeria, we can actually train. I mean, I was discussing with Dr. Osahin at Benin last week, and I told him that we can actually train our technicians to work in the ICUs and train them as respiratory therapists to an extent. Because like in Port Harcourt, I've moved some technicians to work permanently in the ICU. So they are getting used to ventilators in the ICU. So with time, we can actually create programs that we have to train our technicians who have some knowledge of ventilators in the OR. And with this basic knowledge they have, they are the easiest to get trained to. But he was saying that in Benin, no, they said they can't, the only residents, I can't be only residents that should work, in the ICUs. You can train, you can convert, I'm sorry, saying this in the open, but I think they can convert technicians to work. And imagine you, a technician, not tampering with some values on the ventilator, and then you allow it be. It doesn't make sense. It's you, the physician, that you should be much more knowledgeable, to assess your patient and then correlate whatever values you're getting with what you're getting as ABG values. That's what I think anyway. There could be formulas, but those are formulas should not be they are for us to see. And then I don't know.
Thank you. Thank you very much, Dr. Joe, for that contribution. We'll definitely train our technicians in this aspect, but of course, they will be monitored, as you said. Then again, there's another question from Dr. Benga. She is asking about the addition of pressure support to PEEP. That's pressure support to PEEP. So what is the importance of this setting on the ventilator? For instance, PS above PEEP. So what is the importance? Maybe he has a ventilator that is showing both pressure support and PEEP. So he's trying to find out the importance of this setting in the ventilator. Did you get that, Dr. Joe?
Yes, the best way to do it is, place the patient on a ventilator, and then PEEP is for oxygenation. The determinants of oxygenation are the FiO2, the inspiratory time, and the PEEP. These are determinants of oxygenation. So once a patient has issues with oxygenation, you look at the PEEP, you look at the inspiratory time, you look at the FiO2. These are the things you adjust, you play along with on the ventilators to improve oxygenation. Then the determinants of ventilation, which is the carbon dioxide clearance, you now talk about the rates, and I can talk about the tidal volume, the rate and tidal volume, that are the things that are determinants. For pressure support, for a patient who is spontaneously breathing, for a patient who is hypoxemic, let me just mention like maybe a COVID patient, SpO2 is 85%. The patient has problems with hypoxemia. So, like I said, the determinants of oxygenation are the FiO2. You increase the FiO2 to 60, 0.6, 0.7, and then the PEEP, you move PEEP from 5 to 10, and then you watch the SpO2, the oxygen saturation, and see whether there will be improvements. You've already tinkered with the determinants of oxygenation. You expect there to be improvements. But for a patient to have a satisfactory ventilatory efforts, get this right, for a patient to have satisfactory ventilatory efforts, there are patients who are hypoventilating, either from pain, from the disease, or whatever factors. They are hypoventilating. So you want to support, but they are making some spontaneous efforts. They are breathing on their own. You want to improve the efforts they are making to a much more satisfactory level. You use pressure support. So when you put this patient who is on a ventilator, who is making 250 mils, it could be having adequate oxygen saturation, maybe 92. But the volume, that's the tidal volume, what about the VTE, the exhaled tidal volume, is 200. That would be like not adequate for a 70 kg person. So when you put the patient on pressure support, the patient is on PEEP. The PEEP is basically to improve oxygenation, but to increase the patient's efforts, the efforts at breathing, so that the patient will generate enough tidal volume. You need to tinker with the pressure support. So when you increase the pressure support of 5 or 8, you see the tidal volume. You just try this on the ventilator, or the patient on the ventilator, whose the exhaled tidal volume is 200. Increase the pressure support from 5 to 8. From 5 to 8, you see the tidal volume, the exhaled tidal volume increasing from 200 to 300 to 400. So the pressure support is to increase your targeted volume to a satisfactory level. I want this patient who is making 100 mils to make 200 mils or 300 mils. So for the patient to make 300 mils, you're trying to support the person. In late terms, you're trying to, it's like you're encouraging somebody, you have to breathe very well low. You have to breathe very well low. You have to take a deep breath. So the pressure support is to encourage you to take a deep breath. It's not trying to, that one has nothing to do with the oxygenation. Oxygen is a PEEP factor, PEEP FiO2. What helps the patient to increase the volume is exhale or inhales is the pressure support. So you can have a pressure support PS, you can have a PEEP, perfect. And that's what the bi-level is. I talk about the bi-level ventilation. Bi-level means 2 levels of pressures. The first level is the continuous airway pressure at exhalation, which is the PEEP now. The next level is the support you are giving the patient. So on a ventilator, if you see a PS and you see a PEEP, it shows you are using a bi-level, which is one of the winning modes you can actually use. So bi-level, PEEP, PS, and PEEP, that means bi-level. It's same you're having a Cpap plus a PS is bi-level. So bi-level is inspiratory positive airway pressure, which is what the pressure support does. And then the PEEP, which is the positive end expiratory pressure, which is what the Cpap does. So basically, that is perfect. It's a perfect setting on the ventilator for those who are spontaneously breathing.
Okay. Thank you very much, Dr. Job. Thank you for the explanation.
But excuse me, there are very perfect people on board. Dr. Shinake is on board. You can assist me, please. Yes, so that I can help explain these terms.
Dr. Shinake there? Okay.
Yeah, he's doing a very good job. I do not need to add. He's doing an excellent.
Okay, sir. Okay, sir. Thank you very much, sir. So, thank you, Dr. Job. Okay. Sorry, ma.
Up his hand. Dr. Oshinaike has been raising his hand. Can you recognize?
Okay, Dr. Oshinaike, can we?
Okay.
Dr. Oshinaike, welcome on board.
Thank you, President, for finding me.
I've seen your hand since.
Yeah, my hand since. Thank you, Joe, for the presentation. I'm sorry I didn't join on time, but I joined when the questions and answers started. I just want to make a few contributions. I think Job answered that perfectly. The truth is, but I want to just add something to what Job said. I think our technician at this level cannot function as a respiratory therapist. Their training is far, far below what you expect for respiratory therapists. I think it would be more appropriate to think of a physiotherapist who has training in cardiopulmonary rehabilitation. They function better as respiratory therapists. So I think it's important to know that, because we are talking about very sensitive aspect of care, ventilative therapy. And it's not something you can just leave for anybody who is not very well trained. So I think that's important. Then the other thing to note is that, yeah, respiratory therapies have some formulas. Is because because their level of support, their level of training, they need to be guided. They need something to provide some like a guideline for them to follow. And that is why most of them will make use of such formulas. But as Job said, the intensivist is the one in charge of the patient. So your training should allow you to know what how the PCO2 is affecting your patient, whether you want to increase the rate. And I want to add, Job, it's not only the rate. You can actually use the volume also to cut down your PaCO2. Okay, so
Hello, where are we, please?
Yeah. So
yes, Dr. Shinaka is talking. Yeah.
Yeah. So, I want to say that as intensivists, you have the training to guide you to know the appropriate PaCO2 for your patient. Okay. I mean, if you want to achieve some level of oxygenation, the so-called permissive hypercapnia. Okay, so Job has tried to answer most of the questions. I also thought to add that when it comes to PEEP and pressure support, I want to sound a note of warning, because PEEP gives a level of pressure. Pressure support gives you a level of pressure. Your eyes must be on the airway pressure. Okay, average mean airway pressure. Because if you are not careful, you'll be shooting high, and the pressure, especially if you are not on a pressure control mode, your pressure might be too high, and that might be injurious for your patient. And we know the platelet pressure. I mean, we don't want it to get too high. I mean, above 30. So when you are, I mean, there's a factor of intrinsic PEEP there. So if you are not careful, PEEP and pressure support, you may actually be shooting your pressure. I mean, your pressure might be getting too high. So just for us to note that, it's good to give some pressure support. It will really help your patient, especially when they are the inspiratory pressure is not adequate. But note that you must keep an eye on the total airway pressure. Thank you. I think I will stop there. Thank you very much.
Okay. Thank you very much, sir. Thank you so much for that contribution. Looking at the chat box, I don't think we have much. It's just for us to know about the payment channel. Our NSA website have been rebranded, and we can actually pay our dues through the payment portal. So please, takes a lot of money to organize this time. People are putting so much effort, making sacrifices. I think paying our dues using these payment channels is just the little we can contribute for NSA as NSA members. Thank you so very much. All these voted, thank you for your time. I want to invite Madam President, who will be in charge of I don't know if we are still going ahead with the other session, the questions and answers.
Hello.
Hello, ma'am.
Thank you.
Yes, ma'am.
Thank you, Nkechi. Thank you, everybody. Thank you, Dr. Job, Dr. Gafar, and all the people that contributed, Dr. Shinaike. We have already been on the second session for the past 15 minutes. The first question was on respiratory. The first question was on respiratory therapy, and different people have given their different opinions. My take on it is that we don't have that cadre of staff in the healthcare system in Nigeria. We don't have people trained for that. Respiratory therapists are graduates. They are not technicians. They are graduates who have finished an undergraduate course, like the nursing degree, but this time in respiratory therapy, and then they are trained on respiratory physiology, intensive care, resuscitation, and then they are trained to work with patients with respiratory impairment. They examine patients that have breathing disorders. They consult with physicians to develop patient treatment plans. They can perform the diagnostic tests, like you can tell them to do lung function tests on the patient, like measuring lung volumes and capacities. And they can use chest physiotherapy to treat patients. They can give aerosol medication, so you can ask them to use inhalational medications for patients, asthmatics, patients with COPD, patients in ventilators. And they record patients' progress, and then they teach the patients how to take the ventilators, ventilatory equipment, how to use them. Like patients that are on oxygen, home-based care, they teach them how to use it and all that. So you will agree with me that it's a highly specialized field, and it's not something that we will say we can train our technicians to do that. We should not even go there at all. We don't have them in the practice in Nigeria. We don't have them. That's all. We do that component of the job as anesthetist and intensivist, and then some pulmonologists, some physicians who are pulmonologists who have taken training in pulmonology are also able to do this. But we don't have many physicians who are also pulmonologists and intensivists in Nigeria for now. Maybe it's an area we can explore, that people will finish fellowship in internal medicine, specializing in pulmonology, and then come and or a specialty in critical care. That is an area that can be tapped. That's a resource that can be tapped when the need arises. Thank you very much. That's my take on that respiratory
Thank you, ma.
therapy bit. What's the second question you had?
No, ma, that is just the question, ma. The other chats and the other contribution on the chat box was just a suggestion that some of our colleagues in the diaspora, this is from Dr. Luca Yode, he said some of our colleagues in diaspora should come around, maybe who are intensivists, to train us through webinars like this, share their experience on how we can troubleshoot the ventilator. So that was what it was just a suggestion, Max, not a question involving our colleagues in the diaspora who are also intensivists on how to troubleshoot ventilators.
Yes, we have responded. I have responded to that on the chat by saying that every member of NSA who is interested, we consulted everybody who was interested to give us lectures, and everybody responded. But we didn't know those are in diaspora, so we don't really know who is where. The lectures are not based on where you're located. It was based on interest and commitment.
Okay. Yeah.
Starting from either May or so, when we start the next session, it is left open based on the specialty. People can be contacted to give their lectures. You said there were 2 questions in the NSA email. What's the second question?
Yes, that's the one with Job have addressed that, the second one. So we are through with the questions.
What's the second one? What was the second one?
Okay, it is from Dr. Benga. He was asking about he was trying to find out about pressure support and the use of PEEP.
Okay.
And Dr. Shinaki have dealt with that. He took answered the question. Yes.
Okay, what we wanted to generate were questions that are related to exams that can come up from any area of the exam, be it primaries, membership, part 1, or fellowship, part 2. So we wanted members to ask maybe questions that they think they want to get clarification on, or how to approach questions and all that. So if there is any other thing, I see Dr. Job is pasting some things. If there's any other question on the chat box or any explanation from anybody, we can take it in the next 5 to 10 minutes and we round up.
Okay.
I got a formula that Jamie sent to me from Saudi Arabia.
Okay, can you explain the formula? What is it about? Any explanation?
I don't think Dr. Job. Dr. Job, we're asking for the explanation of the formula. I don't think he's there anymore. I think we have lost this network, ma. Hello, ma.
The formula is in the chat box, but I don't know how.
Hello, ma.
Yeah.
Yeah, I think he was trying to explain it, but maybe his network went off. But from what
what I saw is respiratory
rate
times CO2 equals to respiratory rate times CO2. So I don't understand it. That's why I wanted somebody to explain. Is Dr. Lumelu on this call?
Good evening, ma. Yes, I'm on the call.
Okay, Dr. Lumelu, thank you for that. Please, can you expatiate?
Okay, I had to get some clarification because I noticed that they use this formula and it's not a formula I was taught. But I think what they do, based on what I'm seeing here, it's a bit clearer for me. Once you do the ABG, you get the patient's, I think, PCO2 and the current respiratory rates that the patient is on the ventilator. And perhaps the PCO2 might be so high or so low. Now, normal PCO2 should be between 35 to 45. On average, it should be 40. So you look at your current PCO2 from ABG and the ventilator setting. And if the PCO2 is not correct, you now try to adjust the rate. This is just using rate based on this formula I'm seeing here to the desired level of 40 millimeters of mercury. It's like this formula we learned in chemistry: concentration of volume is equal, concentration times volume is equal to concentration times volume on the other side of the equal sign. So your set respiratory rate plus your actual PCO2 you get from your ABG, you will now adjust, you want it to be equal to the new respiratory rate that you would, ventilator rate you would set to get a desired PCO2 of 40. This is what I'm understanding from what he has written here. Because what I notice is they just take out their calculator and start arguing with me that it should be this rate. And I'm like, how do you do this? So it gives me a little bit of clarification seeing this. Maybe the patient is on 12, let me say 12 breaths per minute, and his PCO2 is 60. So that'll be 12 times 60 divided by the other respiratory rate you want to set times 40 as your desired. you're going to have 12 times 60 divided by 40, the kind of cross multiplication thing. And that will give you an idea of your set, what you should set the respirator or ventilator rate to achieve that target PCO2 of 40. That's how I'm understanding it from this. So they actually just whip out their calculator and start arguing. And then sometimes it's a bit funny. So at least I needed some clarification on the formula, which has been set out for me. So that's the explanation I have. Thank you.
There was so much background. Okay.
So I'm done. Thank you. I'm done.
Okay, thank you, Dr.
No, thank you.
Okay. I guess it just shows the universality of knowledge that there are so many ways to do things. So we have to also know that people have different approaches. Important thing is to arrive at the clinical solution to the patient's problem scientifically. So if they are using the formula and it works, when we're in a different environment, it's part of the adaptation. We have to learn what skills are at our disposal to get us to where we want to go and to make us relevant. I don't know, Dr. Gafar, do you have anything to do or say as the moderator? Okay,
first
go
and
ahead.
foremost, I'm actually trying to lay my hand on the formula. Actually, there's a formula. If a patient is placed on mechanical ventilation, then there are abnormalities which need to be corrected by the respiratory therapist. They actually use a formula, but everything. So maybe when I get a clearer formula, I'm trying to check my slide, then I think I'll post it on the NSA WhatsApp group for everyone.
Okay, what I think you should do,
yes.
What can I make a suggestion, Dr. Jafar? Since you're
I'm
taking
listening,
the second, since you're taking the second part of the presentation, why don't you do the ventilatory mode? Why don't you do the ventilatory mode and then how to set up a ventilator next week? So by then you will have gotten all the formulas and maybe you can also interact with Dr. Elumelu and any other person so that we'll be on the standpoint of sharing of accurate knowledge. You understand what I mean? You still have an opportunity to take us next week.
I think like you said, Ma. Are you hearing me?
Yes.
Yes, I think like
yes,
you
I can
said,
hear you.
And there's no formula that is strict. I think the end point is what is most important. You know, serial arterial blood gas analysis and changing the variables. Because even the formula, you need to be changing it from time.
Yeah. Okay. All right. Thank you very much.
Hello, Mama.
Dr. Hussein, yes, go ahead.
It is the presenters and my senior colleagues.
Dr. Hussein wrote something on the chat box that current PCO2 times current respiratory rate, desired PCO2 40 times desired respiratory rate. So that's the formula that he presented. I think that was what Dr. Elumelu was trying to explain. So what we do is we adjourn this part of the discussion till next week. Then we have a clear-cut, detailed explanation by Dr. Gafar, who is also into critical and intensive care medicine. So we can take, we just have 12 minutes to go. If there is no other comment or question, I just want to say something. I want to say that we thank all the people that have joined us, and that please, we're encouraging members to pay their dues, and new members, when joining, pay your subscription fee and pay your membership, your membership fee and your annual subscription. And then send your phone number for WhatsApp to the secretary or to any of the ESCO to add you. You can also link up with your zonal coordinators, and they can also assist. So back to you, Dr. Gafar. Hello. Hello, back to you, Dr. Gafar or Dr. Nkechi, to close this session. Please, the next week's presentation is by Dr. Gafar. He will be talking on ventilation part 2. And we are asking residents who are doing primary or membership part 1 and fellowship part 2 to ask questions, maybe exam questions or mode of approach of exam or whatever. We will take the second part of the question and answer next week. Thank you very much. Also, the NSA account number has been pasted, and the secretary will tell us more about it. Thank you.
Thank you very much, ma'am. I want to thank everyone who joined this webinar series today. Thank you and thank you to all the presenters, to all those who made contributions, even all those who asked questions and contributed. Thank you so much for this. If everybody is not showing interest, there's no way NSA will move forward. So I want to thank you for your time and your interest in the NSA. So without wasting much of your time, I think at this junction we can call the meeting to a close. We can observe our individual closing prayers. I don't think we need to take a common prayer. We can observe individual closing prayers. And as the President has said, please, let's pay up our dues. We have the payment portal right on the website. It's very easy. Just go to NSA website and type it in. You will see payment portal. You can always send evidence of payment to Dr. Seidu Yakubu, who is the treasurer, or you can send to me directly, secretary, or any of your zonal coordinators, or any other NSO ESCO member. You can send to that person for evidence to be recorded that you have paid. Yeah.
Excuse me.
Hello,
somebody asked for the YouTube handle. Somebody asked for the YouTube handle. Has it been pasted?
Yes. Everything
is pasted. YouTube handle and the Twitter
yes,
handle.
Twitter.com official NSA.ng. Instagram is www.instagram.com /NSA Nigeria. We are also on Facebook. That's the https://facebook.com/NSA official NG. I pasted all these links on the general WhatsApp group, so you can see access it there.
Okay.
Too. Yes.
All right. Thank you very much.
Okay. I think we can close at this point.
We'll do our we'll do our photo. Can we take a screenshot of the program for people to see those that are in attendance? Hello?
Yes, we can. Let's put on our videos.
Yeah, okay, so put on our videos. Let me put on mine. Okay. So, Dr. Mukaila, your video is not on. Dr. Gafar, thank you. Dr. Ganiat, we want to take this page. Can we have your video?